Hello and a very good afternoon to all of you watching us live here. Welcome to the brand new episode of MasterSeries session with our experts. Today's topic of discussion is what a physician or a pediatrician should know about pediatric liver transplant. And who better to talk about it than our very own Dr. Neelam Mohan. Welcome, ma'am. Dr. Neelam Mohan, as I think most of you know, is the director of the Department of Pediatric Gastroenterology, Hepatology, and Liver Transplantation at Medanta, the Medicity Hospital. She is a pioneer in pediatric hepatology and liver transplantation in the country. She's performed the world's first successful liver transplant on a baby weighing 2 kgs. She's also the recipient of Dr. B.C. Roy National Award and has been a member of the committee that formulated the global guidelines for the management of hepatitis B and C in children. Dr. Neelam Mohan is an astute clinician, academic teacher, publisher, leader, and a social worker, and also our ad board member in Doplexes. So, welcome, ma'am, and please go ahead with your talk.
Thank you, Darshika, for that kind introduction. I'm truly humbled. And the topic that has been suggested for today in this best month of hepatitis, if I may be allowed to say, because we all know July end, we celebrate the Hepatitis Day. I wanted everybody to know about the basics, what every physician, every pediatrician should know about a pediatric liver transplant. The first thing is, when does a child need a liver transplant? So simple answer is when the liver counts off. So the liver usually goes when it is an end-stage liver disease, which could be a cholestatic liver disease, or most of the time in children, it is the cholestatic liver disease like biliary atresia, or it could be due to metabolic liver diseases like Wilson's, tyrosinemia, glycogen storage, etc. Now, chronic viral hepatitis is not so common seen in children like chronic hepatitis B or C. What we see actually is the chronic autoimmune hepatitis, which is more common. Then comes the acute liver failure. Acute liver failure most of the time is due to hepatitis A or E. But in children, even Wilson's can present, like some metabolic, like Wilson's can present with liver failure, or autoimmune hepatitis may present with liver failure. Sometimes we like to use the word acute on chronic liver failure. That is just for the experts to, but it's a category within this that there's an underlying liver disease. And this is something which I would want every physician to understand is the inborn errors of metabolism, which affect the liver, and when the liver is damaged, we all understand. But there are certain conditions where the liver is not damaged, and the effect is on some other organ, like say urea cycle defects, organic acidemias, where like citrullinemia, MSUDs, I'm just giving example, where the effect is on the brain because of ammonia, you're not able to eat a diet and all that stuff, acidosis. So, but the culprit, if you change the liver, maybe the enzyme which is deficient gets corrected, and so the child is sort of cured of that condition. So that is also an important condition where you can do a transplant before that organ is damaged, preferably, especially like brain. If you have an irreversible damage of the brain, then it gets difficult. Now, primary hyperoxaluria is a condition where the kidney stones are formed, but the defect of ATG enzyme is in the liver. So I need to change the liver, or I need to do a combined liver kidney and not isolated kidney. And then, like in the adults, sometimes we do see liver tumors in children, and we either do chemotherapy or liver resection of a part. But suppose if it is, affecting both the lobes, not responsive to chemotherapy, and it has not got extrahepatic spread, then I can do a transplant and cure this child. And occasionally conditions like factor 7, protein C, protein S, where there is so much of thrombotic disorders, bleeding tendencies, etc., that you want to cure by giving a liver. So the next question comes, when is the ideal time for a transplant in a child? Now, this is for the physicians to understand simple language. when do you get decompensated disease? So we usually look at INR and albumin, and most of our severity scores are based on these two parameters besides bilirubin. And in children, we like to look other causes like growth failure. And there are conditions like severe portal hypertension when you want to, they make the albumin and INR may be okay, but there's issues when we would want to transplant, and severe pruritus like in PFIC, we would like to transplant. So these scores, we are used to it. The child Pew score, when there's child C, we know that the time left is very short. We should go in for a quick transplant. Child B, you still have some months time, and that is the time you might decide to, list the patient on the cadaver and start talking about transplant. There are the scores called MEL scores and EL score. So MEL score is more than 12 years, where you have your creatinine, and PEL score is for less than 12 years, where you include the growth parameter. But now we've started looking as with PEL score and creatinine recently, and we feel that that is a very useful parameter. Now, pre-transplant also we need to be working on as a physician. We need to look into the nutrition, we need to look into the vaccination, we need to be monitoring the growth, the development, and all that stuff. And remember the ideal time to send the referral of the patient to the hepatologist who's into transplant, because there's the right time that you would like to talk about it. Now, we remember when we talk about malnutrition, earlier studies in 2099 also clearly suggested that those who are malnourished have a poorer survival rate and also more morbidity. But over 20 years, this recent paper of ours of 400 experience, we've been talking about more morbidity that is there, that's morbidity with increased risk of sepsis, complication, hospital stay, cost, etc. But the survival was not so much changed. And so this is the paper we presented where we are talking about biliary complication, ICU stay. And so another thing I just wanted to break a myth. Most of the physicians think that the transplant cannot be done when the baby is small, the baby should be 10 kgs, etc. And so though we try to work on the nutrition of the baby before and see if we are able to achieve a good weight gain with nutrition, then we try to wait if it is allowing us and it's not an acute liver failure case. But sometimes there is nothing like a magic weight. If you're not able to achieve good results in growth, even with nutritional efforts, then you realize there's no point waiting, and then the child will continue to go down the centiles with further waiting. And in our series, 37% of the patients, we did less than 10 years, less than 10 kgs, of which 5 to 7 kgs was the median age weight that we were doing. So pre-transplant, we are looking into vaccination, nutrition, rehabilitation, growth, development assessment, but don't forget even the psychological impact on a child, and we do like to look into that too. So the next question comes, you decided who needs a transplant, you decided when to need a transplant. So the next question is, where does the liver come from? So the liver comes either from a brain dead, which is the cadaveric but sadly in India, we don't have that. So we go in for a living-related liver transplant. So for a living-related liver transplant, it is because the liver can regenerate for someone who gives the liver and for someone who receives the liver. Do you need a blood group matching and rather than a HLA matching? That's what we do more over there. But in small babies, sometimes we take a part of the liver and reduce it further on a bench. That is called as a reduced graft. And split graft is of a cadaver. I use one part in an adult and a child. That's called as a split cadaver transplant. But a living-related person can give you only one part. Why? Because God has given you extra liver. You can donate and your liver can regenerate. So who can donate? Anybody who's a willing family member who's without any psychological compression by the other family members. 18 to 55 years, not very obese, good liver function, Hep B, C, HIV negative, and a non-fatty liver. So we do the testing to check that the liver is not fatty. We like less than 10% fat and occasionally go up to 20 in some left lobes. So is mother better, father better, uncle, auntie better? Nothing like that. But maybe in our study that sadly mothers donated more than thrice as much as fathers in this paper which I presented in 2014. But there was no difference in morbidity and mortality, even if you use a O group for a A or a A group for a A. So do you need blood group matching? Ideally, yes. We would like to do that and not necessarily HLA matching. But sometimes you don't have a liver matching for your family. So I want to donate. So I have A group and somebody else wants to donate, they have B group, but they need A. So I will give my liver to that person and that person family will give to my family. So this is called as swap liver transplant, where both of them are equally benefited. And India's first swap liver transplant was done by a center in 2007. So 9. And this was what which we talked about. And the child is doing brilliantly well now, more than 13 years down the line. So sometimes what happens, I'm not able to get a swab and I don't have a family member. This child is O, father, mother are B, grandmom is A. So what do? This is a real case where I was stuck. I didn't know what to do, could not arrange a swab. Child was extremely critical, was initially on ventilator, got out of it. And so we had a narrow margin and didn't want to waste time. So this was India's first ABO liver transplant incompatible. So we gave the grandmom's A group to the child. How can I do that? So we removed the antibody against against that from the child by using a plasma pheresis or a immune absorption. And sometimes we use rituximab in older children more than 8 or with high titers. And all these kids are doing very well down the line, as you can see. So normally if I get a liver, so my liver is bad, I need to throw that liver. But domino liver is where instead of throwing my liver, the patient's liver, I can give to somebody else. How is that possible? Because say if I'm deficient in some enzyme in the liver, so but that enzyme is present in the muscle of somebody else, then I can give my liver to that person who has it in the muscle. This is exactly what happens in MSUD. And was the world's first domino liver transplant, where less than 2 years old boy gave the liver to another 2 years old girl. So that liver, instead of throwing, you can use it. And these children are now, as you can see, more than 13 years down the line and doing very well. There are some conditions like factor 7. So in this, there is bleeding, this child. So you need a transplant just to give that and correct that severe deficiency, which I was talking to you. And when you have some conditions like you need a combined liver kidney, when do you need that? You need that when, unlike in adults, not diabetes, etc., we don't see with kidney failure. We see metabolic conditions like, say, Alagille syndrome with chronic kidney disease, or a polycystic liver and kidney disease, where you need the kidney is bad and the liver, so you need a combined liver kidney transplant, or hyperoxaluria, where even if I do a kidney transplant, the new kidney will choke. So I need to do the thing. So we've done, the first was in 2007, and we've done dozens after that. Now, what is very important in acute liver failure, and is I like to impress on to you, is that you need to immediately, the physician, once you get a patient with acute liver failure, should shift to the center where there is facility for transplant before the child gets very late. You may think you can manage the child. I agree 60% will survive liver failure with a good care, but that 30-40% who might need a transplant, and then transporting them gets very difficult. So there are clear-cut guidelines for transport. You need to talk to the center before you send in an ambulance or an air ambulance. You might decide to intubate a child who's already in grade 3, good venous access, continuous monitoring, infusions, etc. All this should be taken care of during, and not just ask a prescription and say, go to a center. So how much graft do you need? You usually need 0.8% of the weight of the person. If I'm 50 kg, I would need 400 grams that way. And how much I should leave, if I'm donating at least 30% of my liver, which is not steatotic, the healthy liver should be left behind for me. And that is the minimum it should look. Never you would have heard, but in a child also I had 93 kgs. So we cannot give one lobe. So 2 sisters had to give both right and left lobe. Only then I could make the liver adequate to get. So even with that 0.8 in a liver failure, we were not able to achieve it. And this also rarely you do. So a donor is a God. You need to do all the testing to check the fitness. So you do systemic examination and psychological. Then you look whether there's no fat. You look at the vessels. You look at the veins, arteries, ducts, and all that stuff. And then choose the donor and take for the surgery, which is usually a 10-hour surgery. So surgery is just started in the donor, and then once the liver, and then in the recipient, you look at the liver is healthy, fine, what you thought before, and then you open up the recipient, you remove the bad liver. By the time this liver is cut, you get it to this new next theater and put the liver into that. So you cut the vein to vein, you connect vein, artery, and duct. In a smaller child, you do duct Roux-en-Y anastomosis. Bigger child, you can do duct to duct anastomosis. So children are much more complicated, and the surgical expertise that is needed in them is much, much higher than an adult, because the small volume, small area, small vein, small artery, and the small volume that you're playing with. And this, I was showing that sometimes you need to even put a graft. You cannot even close the abdomen with the liver. And can you believe this girl is so beautiful, as you can see on the right side, and she was transplanted when she was a baby, and we could not even close the liver at that time. So can donor surgery be done to prevent a scar? So then we use a robotic surgery to prevent a scar on the donor, especially in the lateral lobes. And remember, it's not all about just one day when you talk about the transplant and the pre. So it's the whole team. Then subsequently, you need to have the right surgeon, right anesthetist, the intensive care, the radiologist who's managed, especially interventional radiologist. Suppose I'm doing a 7 kg baby and I need to do thrombectomy, or I need to do a duct issue, so a PTBD and that. So you need to have a very strong team, and not start a transplant because, you have a hepatologist or a surgeon who are there. You need the entire team which is there. Of course, those who start, they already have the blood bank and lab, needless to say, but a good nursing care and a physiotherapy center. So a setup of pediatrics should definitely be there. And subsequently, now you've transplanted, you've got the child into ICU. So first week, I'm very bothered that there should be no infection or thrombosis of the vessels or biliary leak. And usually later part of first week starts the rejection into second, third week. I'm seeing that there is no rejection and reactivation of CMV virus, or again, biliary and vascular may continue into this week. So we keep doing Dopplers on them and we keep monitoring their test. But on an average, we discharge them usually between 2 to 3 weeks. And post that, late complications within a year, you should be careful. You're looking into the immune suppression. So you should be looking into rejection, infection, and very rarely 2-3% may have PTLD secondary to EBV viremia or high immunosuppression. So there are some complications related to allograft and some due to recurrence of the disease, like autoimmune can recur. We don't see hepatitis B and C so much. Sclerosing and autoimmune are the only one you need to worry that they should not recur. And you need to gradually taper the immunosuppression, keep monitoring for the liver test, the drug levels, and we do check the renal test as a side effect of the drug. How should a pediatrician or a physician take care of? So the normal cough, cold, ARI, in the first 2-3 months, I would always like that they are on higher immunosuppression. They should be close to the center who can monitor. And nowadays with the digital era, you can always have a video consults, etc. Later on, obviously, whenever there is viral, for every viral, you don't need to give antibiotics. Suspected infection, yes, you give. Novel life vaccines, but give them all vaccines and don't deprive them even of the optional vaccines. Monitor their growth. They have a tendency towards obesity because of tacrolimus. They have a tendency towards allergies. They have a tendency towards some behavior and hyperactivity. And then you should not forget the adolescent issues that you need to be very careful. So out of the 400 transplants that we were doing, the smallest was a 2 kg baby, and 37% were less than 10 kgs with a median number of 5 to 6 kgs. And usually chronic liver disease were half a number, and which is chronic liver disease, non-metabolic, I mean. And in that, 80% were cholestatic. Commonest cause is biliary atresia. Acute liver failure was 27%. Metabolic was 21%, and the commonest in that was Wilson's and tyrosinemia. We did small percentage as tumors, etc. So cholestatic forms the 80% of your chronic liver disease, of which nearly 70% of them were biliary atresia. Liver failure, where, as I said, a quarter of them, which are either hepatitis A, E, Wilson's, or autoimmune. And overall survival now with follow-up is close to 86%, and 1 year survival is 95. So we have more than 100 children who are more than 10 years follow-up. We have around 30 with more than 15 years of follow-up. We presented our first data on 200, and we gave our survival rate 89% in them. And as I said, statistically, there was not different in very small baby. These children, whom I said are more than 10 years, 100 children in that, they become doctors, engineers, various work, proud mothers and proud fathers that are now with us. And so we've been, I always emphasize that it's a team which is very important when you talk about the transplant. It's not all about the glamour that some say, you need to start. It is a lot of hard work of the entire team which gets into this. On an average, we do 4 transplants a month, but it takes a lot of time with the big team that you need to be on. We were humbled to have the smallest baby in the world of 2 kg, the first factor 7. These are the global credits in the world. So the first factor 7, the youngest domino, and a chain of transplants, and the first combined liver kidney living related in South Asia. So in India, we also were the first to start with the cadaveric transplant in 2003, and then acute liver failure, the first one in that, and then first into swap liver transplant. The first ABO in India was 2012, and then we moved on to metabolic like MSUDs, citrullinemia. These are very challenging. Hepatopulmonary syndrome. This was the first trial I did in 2016, where you need to give nitrous oxide therapy, etc., because the lungs are damaged and it takes some time for them to recover. And this child was on ventilator and all for nearly a month, and fortunately is doing very well now. So we've talked about, now we've done a series of patients with hepatopulmonary, and these are some questions which people ask about. What is the cost? It costs on a center around 16 to 17 lakhs for a transplant. Of course, the government CGHS rates are cheaper, around 14 or so. The monthly cost post-liver transplant for a medicines is close to, the medicines are now produced in India. So the tablets have cost have really reduced down to 40 rupees or so. And the tablet requirement in children is very less. Unlike the Western, Indians need very little dose. I rarely see children beyond 1 mg or so, 1.5, the smaller cohort. So the cost is much less than within 100 or so. We do get support for those who cannot afford transplants. We do get support to them, provided the papers are okay and genuinely okay. And I think experience and team really matters. You need to just not, tell your patient it's not about the comfort zone in your own village or a city or something like that. You just need to be sure, because it's not one person, it's not me, it's not I, it's all about us, we and us, that makes an impact. Which I said, if you didn't have the right person, if you need a dialysis, you need a kidney expert, the dialysis team, and the interventional radiology team. So the whole thing needs to be the right setup. Where there is, yes, those centers should be doing it. And so I would like to sum up by saying liver transplant is well established in India, and pediatric liver transplant is much more challenging, requires more expertise and a dedicated setup. And with that, it is much more rewarding than in adults, because the results are better and the long-term survival are pretty good. As you can see, we have now 15 years long-term survival and 100 patients of 10 years survival. So once the liver kicks in, then it usually kicks in. You need to be careful. But yes, don't celebrate the immediate success of a surgery. The time has moved where you're talking about the long-term outcome. And I personally like to give personal attention to the immunosuppression and long-term follow-up of all my patients till today. Though I have an experience of 2.5 decades, and we are able to generate a system where we are looking into it and personally monitoring that system. And cadaver organ donation definitely needs to be promoted in our center. And I would just like to tell the youngsters, those who are interested, we do have fellowships 1 year and 2 years, and we have a wide range of work that we do in gastroenterology, manometry, hepatology, etc. And I would like to sum up saying thank you to you all for supporting me. And this award, which was given by the President of India, was for my work in liver transplants. Thanking you so much. I acknowledge all parents, patients, team, media, colleagues, family, everybody for this. Thank you.
Thank you so much, Dr. Mohan. It was lovely hearing you today. We have a couple of questions for you. So my first question is, there is a constant imbalance between the supply of donor organ and the patient demanding liver transplantation. So your expert opinion in resolving the issue, ma'am?
Yeah, it's a very nice question. Sadly, as I said, I've been into 97, I started my training in UK. So since then, I've been into transplants, and India actually it kicked up only after 2005. Before that, just a couple were done, so I can't really talk. But from 2005 onwards, the numbers were decent. And then last decade was a boom where we saw. But what we see definitely is because of the lack of cadaver organ donation in India, we are not able to cater to everyone. But yes, having said that, it's not only cadaver. I think, as you see, we do approximately more than 300 liver transplants a year. So we do all predominantly living related. So, and the results are pretty good in living related transplants for sure. And what needs to be looked into is that everywhere, I mean, India is not like NHS or not like, UK NHS or USA where you get support by the insurances. So it's time come where people have realized the importance of insurances, and insurances need to look into not just the budget in most of the insurances is pretty low, and also for children and also for transplants. So this needs to be negotiated and talked about. This is something which needs to be done at a higher level. It's not possible for me to sit here and shout that the government needs to support, or, I think there are with due apologies, every life is extremely important, but sometimes they end up spending on programs which are related to health, like eradication of tuberculosis, malaria, dengue, etc. So they have their own priorities, and our country is just definitely marching forward. And there are certain states where you get support. So all that is looked into, and that could be the reason why the transplants, there is a gap in there. But as I mentioned to you right now, I wouldn't expect it to be in every city. It is not fair, because the infrastructure that you need, the cost that is involved. Suppose I do one transplant a month, or I do four, the cost of me keeping everybody is going to be the same. So you need to understand that to get the break even. It's not all about the glamour part that you need to understand. And so therefore, we always say that in the Western world also, you would not expect it to be in every city. You would expect it to be allocated. And we Indians should respect that and need to transfer to the centers where it is available.
Thank you so much. Moving to my next question. So, graft failure increases the number of transplantations. So, does having a patient selection criteria help? Also, any other factors that could help bring down the rejection rate?
Failure is not due to indication. Graft failure means and it is seen more often in cadaver, where you call primary non-function, maybe the liver was not good and it didn't kick, etc. But in living related, when you mean graft failure, basically we are talking about where you lose the graft subsequently, whether you lose it due to rejection or you lose it due to recurrence of the disease, which I said is autoimmune or sclerosis. Rejection, what often we see, whenever we lose a patient with rejection, often unless we've had, adolescents who stopped taking. So we've had like 3 children who stopped medications. A child had an argument with the dad and he had stopped for 3, and then he needed a retransplant where his mother donated next time. And so these are the cases where you stop immunosuppression and all, and you had a chronic rejection, sadly, because the acute rejection marched on to chronic and was not addressed. So those are the cases where you would end up with a retransplant or recurrence of the disease. And that is the more common reason. And the other condition is what I would actually call it as the vascular complication or the biliary complication. So basically, because there was a thrombus in the portal vein or a thrombus in the artery, you lost the supply and then the graft failed. But you understand what I'm saying? Yeah. And similarly, a stricture biliary, which was not handled, and gradually the liver went into cirrhosis. So that's other conditions. It's not, it depends again. That's what, as I said, sometimes, I use that you need to get married to the family. What I mean to say is that it's not just about one day and celebrate the success when they get discharged. It's talking about the long-term survival, the long-term follow-up, and that's probably my USP, that I look like a hawk on them. And that's maybe the reason where, despite 37% of the patients less than 10 kg, we were able to give a results of 90% with a 15 years actual survival rate of 85.
Thank you so much, ma'am. Ma'am, a very important question for today. With a change in lifestyle these days, what advice should physicians give to their younger patients to keep liver cirrhosis at bay?
Very, very, very good question. I really like it, that the question, why do you need a transplant? So it is so important to understand that there are a lot of conditions where you need liver transplant in adults are actually conditions which you could have prevented by really monitoring children and taking care. For example, the basic thing, fatty liver disease. I see a boom in fatty liver disease and obesity. And trust me, I'm not exaggerating. You talk to the parents, half the time, they laugh it out. Hi, thoda healthy hai. Either they do that, or the child feels insulted. He doesn't want to come back to you, and you really don't know how to. So it is time when we explain a chubby baby is no more healthy. So fatty liver disease, the need gets started in obesity. So 1 in 3 match up with the progressive, and then they get fatty liver, then they get diabetes, then they get, kidney issues, diabetes, and it's in their 40s that they end up with cirrhosis and transplant. And you call them cryptogenic, NAFLD, and all that stuff. But we could have done something earlier. We didn't know, but now we've shown that actually most of them are this. This is one. So it all is about your lifestyle, what you eat, and how you. It's a balance between your eating and your exercise or your fitness weights. So suppose I'm not, not able to work a lot, then I would try to put a zip around and ensure that it's a healthy protein diet, whatever you're using. So in children, it's not about me. I mean, just passing remark. So you need to get your diet sorted also, because a majority of the Indians' diets are pretty bad. They're very bad in proteins and, more in fats and carbohydrates, and sugars are very high in our children. It is time where we've started saying that in infants, don't even give sugar first year. The reason is you don't want them to get addicted and not get the taste. We're just trying to talk to the parents also. And sometimes I think it is not just the child, it's the family you need to be working on, because both the parents are fat, and so they don't find the child fat. And, it's like, it's difficult, but you need to just work on it. And it's going to be a shift where people understand. And like now the Americans have understood, the whole America is like sorting out with obesity and problems, and that and we Indians, Asians have a pot-bellied fat where the fat gets more into our livers. So we are even so worse when it comes to obesity, and we get all the fat in our livers.
Thank you so much. We also received one question on exceptions to the MELD scoring system. So your views on that, ma'am.
Yeah. So actually what we talk about is, now again, this was a message for physicians and pediatricians, and I wouldn't want them to get confused with these scores. It is just basically, we talk more in the Western data when we want a listing and to get some priority who needs transplant first. Like, so we give a score to do that. And there are some exceptions where you jump up the, based if you have a kidney involvement or you have a tumor. So you jump up the ladder based on certain criteria, but it is basically meant for experts. Just an idea for the physicians and pediatricians that we look into some scores, but in living related, we individualize them and not really put them on.
Okay. Thank you so much, ma'am. One last question for today. So since organ shortage is always a thing, how can the organ utility be improved in certain cases?
Yes. So when organ utility, number one, promote cadaver organ. So you should save your organ. Number two, and that cadaver organ promotion has to come. I mean, it has to be a wave in the country.
Yeah.
That wave in the country only can help it, coming from Modi ji. So next thing is, like in Singapore, your organ will be taken unless you said not to take.
Okay. By default.
In India, you have to sign to take. So even if I sign to take, after the death, my body becomes a right of my family.
Yeah.
And so the family should know that I wanted it to be given. So all that needs to be. And second is that we should use split. Even there are some places where the organs are available, then maybe the expertise at that center should be there, that they should split into an adult and a child, because that is very much more technically difficult to use it on two people than use on one. So there are certain states where they find it technically challenging and just used on one and not on two.
Thank you so much. So this brings us to the end of our program. So thank you so much, Dr. Mohan, for being here and talking to us on this very important issue for today. And we are looking forward to many such sessions exclusively on Doplexes. Also, to our dear viewers, thank you so much for attending today's session. Please feel free to drop in any question or queries if you have. We'll get back to you on the same. And thank you for watching and have a great evening ahead. Thank you so much.